we're going to talk about optimizing antibiotics, particularly in dentistry, and one or two other things. But just briefly, I'd like to thank my colleague, Dr. Wendy Thompson. I've nicked a lot of her slides this afternoon. She's very good at delivering this sort of talk. So on the basis that reinventing the wheel is a complete waste of time, I've just simply, with her permission, nicked them. We'll talk about Wendy a little bit more in a moment or two as well. My name's Susie Sanderson. I'm a dentist by training, many years in general practice. But I was also the chair of the British Dental Association for about 6 years, very involved in all sorts of political things, sort of trade union stuff alongside the science. I'm now, and still am, a member of the Health and Science Committee. For the last 10 years, I've been working as a dental legal consultant, a dental legal advisor for Medical Protection Society, and left that job finally to hang up my pen at the end of last year. So I'm free and about to shout a lot about antimicrobial stewardship, which delights me. I'm also involved heavily in the World Dental Federation, and that document on the right there is a white paper which we produced at the end of last year, middle of last year, again led by Wendy Thompson. But it's trying to encourage the entire world of dentistry to look at antimicrobial stewardship as something which needs to be addressed. As you can imagine, it's very different in different countries. And we're a long way ahead in the UK in dentistry on AMS. And I also work with the Council of European Dentists on raising awareness at the European level as well. Less so now, we're not European any longer, but I still keep a finger in that. This will not come as a surprise to you, this slide. You'll all be very familiar with this infographic. It's Lord Jim ONeill's infographic in his report, which predicted that within 30 years, more people will die from infections than cancer. I suppose it's the thing that really triggered me to, in my declining years, if I do need a hip replacement, I would like that hip replacement to work. And I don't want it to fail from an untreatable infection. And it was as usual, it's all about me. What does it mean to me? Well, I've got some time. Let's see if we can shout and help about this now. And dental antimicrobial stewardship protects general health, not oral health. It's all about general health, and that's why it's so important. And so my raison d'etre, if you like, is to encourage dental teams only to prescribe antibiotics as an adjunct to definitive clinical management of the cause when it's indicated according to national guidelines. We'll talk a little bit more about that shortly. I just stuck this comment in here because we hear this from doctors. And it's I've got to tread very carefully, but it's one of the bits of misinformation that patients use to achieve their ends. Patients don't like forceps, they don't like having teeth out, they don't like having root treatments, they don't particularly like having treatment at all. And if they think an antibiotic can solve that for a while, if not forever, then they will go to the ends of the earth to get hold of a prescription for antibiotics rather than somebody getting the forceps out and removing a tooth or root treating a tooth or whatever is needed. So unfortunately, they play us all off between us. And that is a nonsense. A dentist will never say that. But it's just to put things in context. Dentistry is a killer. I mean, we say we never kill patients. Very, very rarely there's an anaesthetic death. But of course, dental disease has killed and will continue to kill. And in the 17th century, it was the 6th most common cause of death. That little bit there says teeth and worms. And so those are the times when people thought that there were worms in teeth, eating them away. I suppose we could scare the kids with that now, but it's not really appropriate. We do, in England, and this particular toolkit is used in the UK and outside the UK now as well. We do have clinical guidance for dentists about using antibiotics. We also have guidance about using analgesics to help patients through the time when they're in severe pain. And we have patient leaflets, posters, all sorts of stuff to help dentists to optimize their prescribing, if you like. And we have an audit tool. The Health and Social Care Act requires dentists to review their optimization of antibiotics, which we've chosen to interpret as needing to audit regularly their use. And that's not just counting the number of prescriptions that you issue. That's looking at why you issued a prescription and whether it was justified. And there's lots of training. So here's one of the 3 sets of guidance that we have in the UK. They're all very much of a muchness. This is the evidence-based set of guidance. And it invites dentists to look at a patient to see whether there is swelling that extends towards the eye or the throat. Are the lymph glands involved? What's the temperature? Is it raised? Is there trismus? That's when you can't open your mouth, when you're going into a sort of lockjaw situation. Anybody with children who've had wisdom teeth problems or had a wisdom tooth out will recognise that. You have to feed the chips in, flatten the chips and feed them in for eating purposes. And persistent swelling despite treatment. And antibiotics are not an alternative, the guidance says, to actual clinical treatment to remove the cause. So that's the premise of the guidance that we have, and most dentists will follow that if they possibly can. Let's just skip over these because the slides are a bit small. This is just a slide of the audit toolkit, which allows dentists to explore why they prescribed an antibiotic. Was it justified under the guidance, under the guidelines? It's very useful. It's available for all dentists to use in the UK, and many do. This, again, you won't be able to read, but this is during the beginning of the pandemic, the most recent pandemic, anyway, the COVID pandemic, the British Dental Association released news. And this is Wednesday, the 25th of March. At the bottom, there's some news at 5:30, and then there's some more at 7 o'clock. And the 5:30 one says that all routine, non-urgent dental care should be stopped and deferred until otherwise advised. That means dentistry stops. Close the doors, no dentistry. All practices should establish a remote urgent care service, provide telephone triage for their patients with urgent needs during the usual working hours whenever possible to treat with advice, analgesia and antimicrobial means, the AAA that dentistry lived on for a long time. If the patient's condition cannot be managed by these means, then they'll need to be referred to their local urgent dental care system. So no dentistry. Telephone, so if you've got toothache, you ring up the dentist and the dentist says, oh, really sorry, I can't do anything but give you a prescription, really. Prescription for antibiotics or prescription for analgesics, or I'd rather have antibiotics. And unfortunately, we were in a situation where dentists were knowingly giving antibiotics that they knew would not actually make a blind bit of difference and could do nothing about it. There's been very little regulatory challenge about that, which is interesting. It was just one of those circumstances. It wasn't just dentistry in that pickle, but what a nightmare that was. So this will be familiar to all of those who go and sit in the dentist chair. It's all a bit looming, isn't it? And dentistry has, for years and years and years, been, I will say, at the forefront of IPC. I mean, it's just normal kit for dentistry, a normal behaviour for dentistry. And in fact, I've just been talking to somebody who says we're actually over the top. We treat every patient as potentially infective. We treat all their waste as potentially infective waste. And unfortunately, we get bags and bags and bags of waste. And it is causing a sustainability problem, no question. But getting dentistry to go back from that is going to be really difficult. We've always treated every patient as a potential hazard. It just is what we do. We moved into this in March for the local access centres, who were still very wary because everybody was frightened, weren't they? We were all frightened at that time. And actually, as you can imagine, doing dentistry, doing any sort of surgery, kitted out in that sort of material is really hard. But they did it. So what happened to the antibiotics? We've said that that's what we had to do. We had to give antibiotics because what else could we do? The bottom line, the blue line, is the normal rate of prescription issuing during 2019 to 20. The red line is 2020 to 21. And that first little rise up section is the first 2 months. So antibiotic prescribing for dentistry shot up and stayed up at a higher level than normal. It is actually more or less back to normal now, but it stayed up. So dentistry, having made massive inroads into stewardship over the last 5 years, massive inroads into appropriate prescribing, found itself going backwards. And the SPOWER report included the information about that. Dentistry prescribes around about 10% of primary care antibiotics. So we're not an insignificant player in the scale of things. In 2020, prescribing went down throughout the NHS, except in dentistry when it saw an increase of 22%, which, just as an aside, in the States, in the US, and I think it's Canada, dental prescribing went down because most of their antibiotics are used for prophylactic reasons, not for the treatment of pain or infection. So because they weren't doing any routine treatment, they didn't issue any prescriptions. So it just shows countries to country, very different. So dental practice is closed during the pandemic, focusing on the management of pain rather than any sort of routine treatment. And if you tried to get an appointment for a routine checkup during that time, I'm sure you will have had the experience of being put off until the practice could get round to routine treatment. Antibiotics advice, analgesia, the AAA, the already stringent practices for IPC were enhanced and are still. And things are still not back to normal, and we now have an absolutely massive backlog of routine treatment, which of course is now 2 years worse than it was 2 years ago. So the cycle of trying to get patients back on their oral health paths is really very difficult. And the risk of infection is higher than it was 2 years ago. So why are we fussed about it? I'm teaching my grandmother to suck eggs, antibiotics. This is one of the strap lines that we've used in dentistry extensively, both in the UK and internationally as well. We've got several strap lines, but we're using this. When people need antibiotics, they need them to work. So raising awareness using those sort of terms. We're trying to stop this sort of thing happening. This is a submandibular swelling, an incision and drain. Some people love doing this. Some people love a bit of pus and goo. And some people, I mean, it's one of those things where I have to do it almost with my eyes shut, wielding. But nevertheless, it's great for the patients, isn't it? You know, they feel better immediately. So we're trying to stop that happening in the first place. This is not untypical at the moment, because we've got more and more mouths full of things that can blow up like this. But that is a life-threatening issue, isn't it, for dentistry? That's an airway blocker. And it happens, as you know, very, very quickly. And it's not something that a dentist is going to try and deal with in general practice. That's a referral immediately. That's a get them in sharpish. And somebody needs to stick a knife in that very, very quickly. But urgent dental care, actually, giving a prescription is a very slow way of getting nowhere. an antibiotic prescription. The quick fix is to do something. Analgesia, take a tooth out, take the nerve out of a tooth, or write a prescription in extremis to help along with all those other things. I'm not going to dwell on this because it's a difficult slide for you to see, but there are one or two things that are different in dentistry from general medicine. When you take a tooth out, that's a very finite thing. Once you've lost a tooth, you've lost a tooth. And that's quite a big decision normally for a patient. Do you want this tooth out? Because that's going to solve your problem, or shall we try root treating it, or what do you want to do? All those consenting sort of questions went out the window during the pandemic. I can solve this for you, and it's going to be an extraction. And that's had, again, long-term impact. Now people have got gaps, they've got difficulties with their bite. We've got to solve that. It's going to be expensive, it's going to be time-consuming. So big decisions to be made for dentistry. Follow-up for people with pain has to be done. It's a surgical profession. We carry out surgery. It has to be done in practice. So the definitive care needs to be done at some point. Let's just skip over those. Running late, that's always a difficulty for dentistry. I don't know if it is those of you in general medical practice. An absolute nightmare. Once you're behind all day. So if you're behind at 9:20 in the morning, you're behind all day. And it's really, really difficult. Dentists are increasingly losing skills as well. And this is a regulatory defensive dentistry issue. The more difficult it becomes, the less likely the outcome is to be 100%, the more likely a dentist is to refer, because they're frightened of the regulator. We have a bullying regulator. The General Dental Council is a bully. This is being recorded, isn't it? We have a risk-averse regulator who is intolerant of dentists providing care outside guidelines. So how do we diagnose dentistry? This is really difficult, isn't it? Forgive me if you all know this. It's pulpitis is that pain that's very sensitive to cold, very, very responsive to cold, kept awake at night. What does the dentist say when you go to the dentist with toothache? Does it keep you awake at night? It's one of the diagnostic point of care tests. Does it keep you awake at night? Well, it's likely to be a pulpitis. The nerve is inflamed. There's decay in the tooth. It's got into the dentine layer and is touching down on the nerve layer. The nerve is inflamed. It's swollen inside the pulp chamber, inside the tooth chamber, and those are the symptoms. It moves on from that fairly rapidly, usually, within 2 or 3 days. The nerve dies, no response to cold at that stage, but the tooth can be a bit tender, a bit tender to touch. You're aware of something going on. And if you leave that long enough, it becomes infected. A dead nerve will become infected in due course. It's not dead in the middle, in that middle picture, middle infographic there. It's just dead, but it's not infected at that stage. So no response to cold. It hurts to touch, and there's sometimes some swelling as well. And you probably start to pick up the evidence on a radiograph as well. But just imagine looking at this. This is a radiograph of the back 2 teeth and a premolar further forward. Looking down on this in the mouth, you'll see a filling on the back tooth, a crown on the next to the back tooth, and then a crown on the premolar in front of the gap. And it'll look quite normal. What you won't see is that huge dark gap indicated with the green spiky bit there, or the abscess at the bottom of there. So actually diagnosing a problem isn't something that you can do just by having a peer in somebody's mouth with a poor light and no instruments and no radiograph. And the patient will say, I've got this dreadful pain. You look in the mouth, everything looks all right. So difficult to diagnose. Other things that cause pain, dry socket. When you've had a tooth out, sometimes the clot inside that socket will break down, left with bare bone, which is not covered by anything except food. hyperreactive, very painful, but it's an inflammatory problem, not an infection. It's an osteitis, not an infection. So antibiotics are not going to touch that. Needs washing out, cleaning up, packing with something that will allow it to heal underneath. And a wisdom tooth problem, again, those of us with people who've been through teenage will know about this, and in fact you might have suffered it yourself. Tooth lodged up against the other, food gets packed in there, inflammation around the gum. On the face of it, it just needs a really good clean out and the pressure relieving on top of that. But it can be a source of, again, a floor of mouth infection, an airway infection. So it needs watching, taking care. There's grinding, food trapping, wobbly teeth, and mouth ulcers. Mouth ulcers are not infections in the microbial sense and don't respond to antibiotics. There's a picture of pericarditis, a wisdom tooth problem. Again, I won't dwell on those. And then something we don't see very often, but you will see if you work in the most deprived communities. This is necrotizing periodontal disease. It's really, really smelly. And it's really, really, really painful. So you can see those ulcers at the top of the gum between the teeth there. Really painful. And that is bacterial, and that does respond to mechanical cleaning, and sometimes it needs antibiotics as well. So all sorts of different things that can cause pain and either mimic infection, or the patient will think they have an infection. Sometimes it's just inflammatory, sometimes it's an infection. All of these things can usually be dealt with by a mechanical intervention rather than just simply giving a prescription, and are usually best dealt with a mechanical intervention. That, just to orientate yourself, there was the bottom teeth there, there's the tongue on the top right there, bottom teeth there. That all looks, I mean, it's a little bit grubby, but no overt holes, nothing going on there. The patient is in quite a lot of pain. And it's only when you take a radiograph that you see this massive amount of bone that's disappeared here. This tooth is sound, but this tooth has got a big white filling in it and a filling at the side here. And this area down here is a big infection associated with that tooth. But you wouldn't pick that up just from looking at the teeth if you just glanced in the mouth. So we have all sorts of point of care tests. Radiograph will usually give us the information. If not, there are other things that we can do. So what about this one? Does this need antibiotics? What's the diagnosis here? Patient comes in and says, I've got a gum boil. Sometimes the patient doesn't even tell you they've got a gum boil because they don't know they've got a gum boil. It's silent because it's actually releasing the pressure of the pus that's sitting underneath. Two things. One is this really badly broken down tooth, but there's also a bit of root stuck there as well. That doesn't need antibiotics. That needs that bit of root taking out, the grotty tooth taking out, and just letting it drain and clear up on its own. Here's an implant, different scenario altogether. That patient will probably have paid upwards of $3,000 for that implant. And if that's starting to fail, then they don't really want that out. They don't simply want a dentist with a gung-ho pair of forceps saying, oh, well, let's just take it out. That's what the guidance says I should do. So you can see the temptation there to use antibiotics. Prevention in those circumstances is better than anything. Make sure that the implants don't fail. So what happens if you do give antibiotics for an infection? Well, there's the infected, nice pussy yellow tooth. Antibiotics will subdue it back down to the previous stage again. Everything quietens down, but it doesn't go away. And eventually something will happen, the patient's immunity drops or just the natural cycle of things, and it blows up again. So those patients who go to the doctor and say, can I have some antibiotics for my tooth, please? It cured it last time, are just setting themselves up for this cycle. So it doesn't work. So this is the Health and Social Care Committee reporting that we do have this cycle of pain and swelling that's been dealt with by antibiotics, and we've got a cycle of patients who will need long-term treatment. So procedures, taking the tooth out. That tooth on the left there has got the abscess attached to it at the bottom. Can you see that dangly bit at the bottom of the root? That's the abscess. So that patient's fine now. No abscess. It's gone. Tooth's gone. It's got a gap, but nevertheless, the patient's well, hasn't had any antibiotics, doesn't have the issues of resistance. And on the right, there's the procedure to do a root treatment, the other way of doing it. Take the nerve out of the tooth and seal the tooth up so that it can't reinfect. So, hear this as well, don't you, sometimes? The patient says, the dentist said, I can't have any treatment because I've got an infection and the infection will need calming down first. That's rarely the case. And if a dentist says that, they need to refer to the guidance, and a little bit of CPD needed. Or maybe somebody needs to organise their appointment book a little bit more effectively so that they've got time to do things for the patients. Towards the end of the crisis time for dentistry, unfortunately the AAA regime continued to be used because with patients all over the place, stacked up to the ceiling. And the Chief Dental Officer in England and Dame Sally Davis attempted to remind dentists that AAA is not a substitute for appropriate treatment. And really, active clinical intervention will solve problems rather than prescription. We'll skip over this. It's about a piece of research at an urgent care centre. Good news, some patients were absolutely delighted, but one or two said it would have been better if the only action wasn't extraction. Point I said again, taking a tooth out there's no way back, is there? Once it's done. So the World Dental Federation is trying to push this globally, and we're involved in an enormous amount of stewardship noise. My role is really the top part of the triangle there, awareness raising. Just trying to get dentists to have the courage to do the right thing. It's very difficult when you've got a patient pushing for a prescription. I really don't want this tooth out today. I've got a wedding to go to. And anyway, I'm frightened. Just give me a prescription. It's really, really difficult pressure. If you want to find out more about antibiotics in dentistry, there's a MOOC, which is not hard work. I enjoyed doing it enormously. So go to the BSAC, BSAC website, or the FDI, World Dental Federation website, put antibiotic resistance in, and have a look at the MOOC. It's a four-week, very, very easy to do, just an hour or so each week. And I think it will be quite informative. Let's not forget that the whole point about this is that routine dentistry, preventive dentistry, dentistry for everybody will prevent infections. Less tooth decay, less infection, less antibiotic use, less antibiotic resistance. And that's really where we are in dentistry, and we were making great headway with that. We've got to regain that ground again, and we've got to regain that ground in the world in some countries where antibiotics are available at the corner shop. Some antibiotics of dubious quality are available wherever they want them. Really difficult task, not only for dentistry, but for everybody. So, take-home messages. Routine dentistry prevents infections, so that's where we need to focus. We need to treat toothache with a procedure, not with a prescription in the large agenda. We use antibiotics only if there's spreading infection, and review the success a couple of days later. And disseminating information like the antimicrobial stewardship toolkit is really important for dentistry. And we try and do that. You can find that if you go to, well, just put Dental Antimicrobial Stewardship Toolkit in Google and it will find it for you. So thanks very much indeed for listening. If you can do anything for us in the way of stewardship for dentistry, we'd be really grateful. Patients who come to you and say, can I have an antibiotic for my toothache? Could you point them in our direction? We'd be very grateful.